anybody that's in healthcare needs to be both in a constant learning mode and a teaching mode. When you quit in those kind of modes, you might better hang it up, because you can always learn some new things. And y'all, the guys out on the front line, y'all have the toughest job, as far as airway management, because a lot of times you're the only one there, or may have somebody else, but basically you're out in a situation where there's not a lot of help and not ideal conditions. The way I usually do if I'm working with a student is I just go over the chart, go briefly a little bit over the information, and then we go introduce ourselves, and I just say, I'm your anesthesiologist, Don Perry, and this is Matthew Whitaker. He's one of the local emergency responders that's working with us today, and that's about all I do. I don't go say, oh, you're going to be, we're going to have 23 different people opening your mouth and putting it into endotracheal tubes or whatever. So by all means, if you're involved, y'all are all professionals, y'all all are dealing with patients every day when you're on duty. As I said, I usually will do the introduction, and I think that's great. Or you can just say, walk up to the patient as I'm doing it to finish the interview, or go look at the airway assessment. I'm John Smith. I'm a local emergency medical technician. I'm continuing training and working on advanced training, and I'm here to be part of the team. And I have not seen any patients that don't have had a problem with that. Once in a blue moon, some patients will come through and just say, I don't want any student anywhere around me. And we say, well, what about a nursing student propped over in the corner, probably about to pass out? And, oh yeah, we don't want them in there too. They might fall when they pass out, they might fall into the wound. We welcome y'all, and and it's going to be some pick and choose. You're going to have some of the anesthesiologists that will say, I don't know about this one. Y'all, you're welcome to see what I do and learn. Maybe you can see some things, but this one I'm a little uncomfortable with, maybe a lot uncomfortable with. But conventional laryngoscopy is something that y'all all will have an opportunity, have a need to learn, and have a desire to learn, and will have the ability to learn. And that's, as I said, you couldn't ask for a better controlled situation. Generally healthy patients, a little bit pre-selected, pre-oxygenated, non-emergent situations, and if you miss, it ain't no big deal. We still almost always we can ventilate that patient and keep that saturation up, and then decide what went wrong. Y'all are a welcome part of the team, and we, I think, realize, I certainly do, how important y'all are. Y'all might be coming to my bedside or my house one day, and you might be coming to my neighbor's house or somebody I know. And the better skills we can develop and the confidence you have in airway management, the more likely we are to get a good result in the field. So go for it. We're dealing with lungs that, if we walk around, have 80% nitrogen. Nitrogen is not worth a crap for anything, so let's get that out. And so if you can get a good tight mass fit, and the other thing we have in our ORs, they always assign an assistant, so that person can hold the mask on. A lot of them hold it very tight. You can tell they're holding on tight because you're seeing an entitled cap non-penetration real well. If it gets up 90–95%, you can feel like you adequately pre-oxygenated this patient. So what does that do? It just increases your safety margin. If you, instead of having start worrying about, with most patients, desaturation in about 2 or 3 minutes, you have 10–12 minutes. That's even if you don't ventilate the patient very well. And we hopefully going to be ventilating the patient if we have to make the one attempt at the airway. Most of the time you'd like a muscle relaxant on board, because that's going to suppress gag reflexes. When you put in your laryngoscope, it's going to, they're not going to cough and try to push that tube in the next county when you put the endotracheal tube in. So some of them are very nervous Nellies, and that's just their baseline personality, and that may be good. Some probably is a pretty good trait if you're taking care of a patient. If you double check things 4 and 5 times, maybe you'll never miss anything. But as I've said, if I'm not good enough to protect the patient's lips and teeth by watching you exclusively while you're working with an airway, I need to get on out of there. And keep in mind, the most common problem when you get nervous is to do this number on the and fulcrum on the upper teeth. And most of people's upper teeth were fine with that, but some of them are not going to be, and it really isn't a good way. Just remember to keep your arm locked and go up straight up. And once you find the epiglottis, you're usually about 90–95% there. The hooker that's been thrown into airway management in the last 10 years or so has been the video laryngoscope, which almost makes almost everybody look good as far as getting a great view of the larynx. It makes almost everybody not look so good as far as getting that tube into the larynx. You know, when you're doing direct laryngoscopy, which is with your Mac or your Miller blade, you're making a straight line, and with that, of course, you have to do this number where you're flexed. It's your sniffing position, and like that. And if you do that, most of the time, on most people, you have a straight line, but God didn't make a straight line on some people, no matter what you do. Those are the guys you struggle with. That's the ones you use your bougie on to intubate. That's where your assistant, and really, what I do, if I'm looking at somebody, and, they have that, maybe it's a Lynchburg chin, a weak chin, where they basically, instead of having 3 or 4 finger breaths, see anybody in here, y'all look like I have a pretty good chance. But they have 1 or 2. I mean, these people that basically have no mandible at all, just a very short mandible. And those are the guys that the assistant can, or you can basically do it yourself. Just if you're holding the laryngoscope in your left hand and you get in your view, you push the larynx down, and if you want to, most of it's going to be backward, but since you're going to be intubating from the right, that's where the verb, B-U-R-P, you backward, upward, right pressure. And if you get that, well, obviously you don't have any hands left to put the tube in, so you then have to tell that assistant, say, I've got it right here, don't let it move. And 99% of the time, they'll hold it very well there. About 80% of those that you otherwise couldn't rescue, you can probably rescue with the bougie, because you can go a little more anterior with the bougie. And I've done it hundreds of times, and most of the time they make you look pretty well. And don't, my trick is, suggestion is, if you're using a bougie, don't take the laryngoscope out, have your assistant thread the tube on, and then keep the laryngoscope in, and that way you have a much easier conduit to pass that tube and make it. And I'm always, if the bougie's in the trachea and you keep the laryngoscope in, it should fall, and you should be able to go right into the trachea. If this is somebody that weighs 350 pounds and has no neck, and the person you're working with, anesthesiologist you're working with, is looking, they're looking a little nervous. In that case, just have the good sense to say, I'll help you, whatever. That's probably one that they're going to struggle with, in which case, once again, the margin, these big chunky folks, even when they pre-oxygenate, don't really get that much oxygen in their lungs. If you're at rest, you're basically, and you're anesthetized, all you're doing is, the heart's going to continue to work, the kidneys are going to continue to work, and the brain's going to continue to work. Everything else is pretty much taking it easy. So you're probably going to consume about 250 to 300 milliliters of oxygen in a minute. So if you have 3 liters, 3 and a 300 and a 3,000, you say, well, yeah, about 10 minutes before you start getting, and that's about right, And of course, if you struggle with an airway, and with the intubation, that 10 minutes seems like about 35 minutes, but you do want to give them that reserve. As far as the airway assessment, the latest thing I've really started pushing on, because that's probably has been under-advised, is the bite test, where you get your lower teeth and bite your upper lip, which means that you can at least pronate or move your lower jaw forward. And if you can do that voluntarily, you can presumably, the person managing the airway can do it with the laryngoscope. And that's probably, these people that have fixed jaws, the big problems with intubations are the short chins, the big thick necks, the reliable obesity, where they have just, and that's where the Malin potty test, and you're basically looking at the back of the mouth. And if you see the tonsillar pillars and even the posterior pharyngeal wall, you say, oh, that's Malin potty 1. It basically is kind of a test of how well the tongue, how much room is if the tongue is really big, and how much of a problem getting the tongue out of the way is. If all you see is tongue, that's an Allen Toddy 4. Okay? The whole sequence is we want to keep the patients comfortable, so we all want to act like we're part of the team. And y'all are, once again, are professionals. Y'all dealing with patients on a regular basis, so y'all are not going to have any problem with that. And just come in there, and as I said, as soon as we get it on the monitors, we don't have to rush these things, but we don't want to spend 20 minutes putting the patient to sleep. Most of them had Versed, so they're going to be a little bit amnestic or a lot amnestic. They're not going to recall too much once they get in the OR, even though they're still talking. But get them to breathe deeply, or reasonably well, get a good mask fit. And that assistant, as I said, and Baptist assistants are very good at that. And make sure, double check me and make sure that we've got the flow up. Most cases last anywhere from 30 minutes to an hour and a half. And we can talk about, usually once the patient's anesthetized, the airway secure, the surgery started, we can talk about what's going on procedure-wise. So we'll get a little more background about why we do gallbladders or GYN surgery or whatever. And we can talk about airway situations. And the big problem a lot of people have is controlling the tongue. And I just kind of go lateral to the right side of the mouth, and the tongue's, is never going to be a problem because I've done it a million times. But the Macintosh blade does have a natural way of controlling the tongue a little bit better. So that may be why I'm trying to start pushing that for people that haven't formed the bias. Say, let's try the Mac blade. Maybe you'll be better at it than I am. And that's sincere, because I was lousy with the Mac blade.
Could you just talk briefly on the expectation of learning airway management in general and not just being in the mindset of going to the OR to put tubes in people and then leave?
I agree. Everybody wants to put tubes in. Very frustrating. Nobody knows how to mask ventilate anybody. And you say, I thought y'all worked with dummies and all. I think that's not near as problem with y'all have. I think they're almost too delicate with the mask. They don't want to, want to push the mask out. You got to get a tight fit, And most of the time, all you have to do is tilt the head back, jaw thrust. You're talking about this extreme jaw thrust, and with two hands, both hands on the mask, and somebody else providing the ventilation. And the problem I've noticed is a lot of guys that grow a beard are hiding a weak chin, and so you have a double whammy. So I keep saying I'm going to tell some of these guys that they need to shave before I'm going to do an anesthetic on them, but I haven't done that yet. But, okay, so the beard. One other thing that's not as common as it used to be.
The dentures?
Yeah. Yeah, actually, if they actually have dentures in, they have a much better airway than if you... But of course, what do we do in ORs? Because we don't want to hurt people, damage people's dentures by... We make them take it out, which makes an airway that goes from maybe pretty good to a lousy airway because you can't get a good seal. Most of the time with the kind of technique we talked about with the two hands, you can get a fairly good airway on an edentulous guy. Okay. But yeah, by all means, please, if you want to if you go up there and say, your patient's now asleep, they're rapidly becoming paralyzed. A lot of my partners will only use rocuronium, so that's 2 to 3 minutes before they really get adequately paralyzed to put a tube in. So in that case, somebody needs to be ventilating them. Might as well be you, And by all means, I would be excited if somebody said, I want to make sure I can mask ventilate. And so what you do is you start out with the basics. And if you can do it with one hand, fine. But I'm probably, because I've had a few people wake up, bite down on oral airways, plastic airways, and they did it, I didn't do it. But they still had dislodged dental work, so that didn't make them happy at all. So with an oral airway, appropriate size, almost always makes any airway better. A nasal airway, downside of nasal airway is you're going to sometimes get no epistaxis, and you get a lot of blood. It doesn't make your life easier when you want to go in and put the tube in. So oral airway. By all means, if you want to say, I want to give this patient 10 good breaths and make sure I'm really good, and in that case, on the machine, you can read out the volume you're getting. If you put it on the right setting, you can certainly look at the CO2 tracing, and if you're not getting good CO2 tracing, you ain't ventilating that patient very well. Please say that should be very much part of your airway management situation is making sure that you can mask ventilate the patient. Good seal with the mask, chin thrust. If you want to go with jaw thrust, if you need to go with jaw thrust, I'll be glad to bag the patient. You can jaw thrust all you want to. Keep that mask in good shape, and let's make sure that patient is well oxygenated, because even if you're really good and it's a really good airway, it's going to take 20 or 30 seconds to stick a tube in and reestablish ventilation. So yes, please ventilate these patients and make sure that you are comfortable with ventilating. Every patient you put to sleep, even if we put in a supraglottic airway, we can mass ventilate them before for that. And of course, the supraglottic airways, they are great at rescue airway, and I hope they're available and y'all are reasonably comfortable, because the learning curve on that is pretty good. These are nice fill bags, but they're not self-inflating. You have to have decent flow and no leaks to allow these to inflate, and then they're pretty well. And of course, once you get a feel for it, you can adjust to it because if you have too much flow, you're going to distend the lungs, so that's not good. So just open the flow a little. You open it, let a little gas out. Make sure you got a comfortable where each breath. It should reinflate fairly quickly between breaths. It has to have flow into it, and you're in anesthesia training for about a minute and a half before you learn your best friend is the flush valve. What does that do? Well, you may have 8 or 10 liters of flow going through there, but say you just put on a mask and you look over there, this thing is kind of limpy because unless you have flow through there. So we have on the side of the machine at the end of the circuit a APL valve. Basically, you close it all the way and nothing leaks out. If you open it all the way, it's pretty much everything leaks out. So you want to pretty well close it, and if you still say, I want to go ahead and fill up this bag, push that green flush valve. Every machine has it. If you don't know where it is, please ask us. We'll show that. And it automatically gives 50 liters per minute flow, so it will fill up this bag very nicely. But yeah, these things are worthless without good flow, because if you don't have this fill, you're not going to be able to ventilate the patient very well. Good. So you get a nice tight seal. This is a little there. And so 3 to 4 minutes, probably about optimal. So you want to, again, check your flow. You have your flow meter over here. Make sure it's 5 to 10 liters. And you always double check it. It's great, it's the kind of situation where, please, if you see something that you think doesn't look right, bring it up. The worst will happen is that it was okay and whatever, but the best might be, oh yeah. I mean, sometimes you'll go to intubate a patient, and of course, what do? We don't have this little girl's not going to close her eyes, but there's a lash reflex. So if their eyes are closed, you stroke the eyelash, if they're still awake, what are they going to do? Blink. And if they're asleep, they're not going to blink. But yeah, the lash reflex, I do it on everybody, because I tend to be on the I wouldn't say low side of propofol, but there's some people I work with that think 250 is a starting dose of propofol, and 300 is probably about what most people need. And I just don't find that I need that more. I also give a fair dose of lidocaine, because lidocaine, what we're trying to do is we're trying to balance cardiac suppressants, and propofol has some vasodilatory cardiac suppressant. So in other words, it can knock out sympathetic tone. So you don't really, if your blood pressure was 120/80 when you started, you don't want your first blood pressure after you put the tube in to be 230/130, and you also don't want it to be 70/40. And I've been both places, and so you want a decent dose to block intubation stress. That's why I like 80 to 90 milligrams of lidocaine. That's a personal bias. Not everybody likes that much. Most people like some. And appropriate dose of propofol. And of course, what's the first drug we give? We give fentanyl, because it's a 2 to 3 minute drug, but you need it for once again, you're trying to block the pain response to doing what we're about to do, okay? So, but if you happen to notice that the IV is not running well, in other words, if I go and say, well, darn, why is she still coughing? Oh, that dose of sucks only made about half of it in, because the patient moved a little as they were going to sleep, and the IV was a little bit positional. So you then straighten out the arm and you let the succinylcholine go in, and you say, now we're going to have better conditions. So it doesn't hurt to have an extra pair of eyes looking over there. Make sure that oxygen is going in when you're pre-oxygenating. Not going to do much good if it's not on. And the IV is going, all the medicine is going in the IV, okay? And what you're talking about is the difference between sleeping in your bed at home at night and anesthetic sleep, okay? If you're sleeping in your bed at home at night, somebody does this, you're probably going to open your eyes and wake up and whatever, even if you're not paralyzed. But if you're an anesthetized sleep, you will not blink or whatever. And anesthetics, you want the patient not to recall. You want to blunt their cough and laryngeal and gag reflex. Of course, we cover ourselves with succinylcholine or rocuronium. you paralyze muscles, you blunted those reflexes even if they're not very anesthetized, so-called paralyzed, asleep, awake intubation, so to speak, which you might have to do if somebody's an extremist where you say, I don't think they'll tolerate anything, sedation. But if that, so all you have to do is stroke the eyelashes, and yes, they'll be closed, but if they haven't gone to sleep yet, they're going to blink.
Yeah.
So then you back off and you either give them more medicine or give them a few more seconds for that medicine to make the circulation through into the brain. Propofol is a very lipid soluble drug, so as is fentanyl, so it goes to the brain very quickly. And you tell the assistant, who's always going to be right here with this tube in their hand to help you out, and they'll kind of do whatever you want to. And this, obviously, what you mean is you lock this and you go up like this, okay?
What do you mean go up?
Your wrist is locked, so you're not doing this fulcrum kind of stuff.
Mm-hmm.
That's where teeth and whatever. And of course, I'm watching, and it's certainly fine for you to watch and make sure. This is metal. I mean, this is serious stuff. You can bruise a lip, and if you're really reasonably cautious, you won't bruise. You really don't want to have to go to the patient afterward and say, that little ding in your lip, which is going to be fine. It's because I was a little careless when I intubated them, So, but you want to just maintain this whole thing. So you want to basically just act like this is locked. So you lift up in that direction from here, okay? Right? If somebody comes for a routine surgery and I knock out 2 teeth, they're not going to be happy because they're not going to think I saved their life. They're just going to say I was careless. So we've had this going for 3 minutes. Vital signs are good. We've given some medications. Yeah, you're going to be like that. And I can be glad to squeeze a bag for you if you want to get a good feel. And so very quickly we're going to decide whether or not we have a good airway. We move in the chest. As I said, this machine, if you put it in the right setting, will tell you the volume. We're getting 300 to 400 mLs in. We're pretty good. We're seeing a good entitled CO2 tracing. So you're doing a great job ventilating. Okay, so now you're going to. So the drugs have worked. You've shown that you can mass ventilate, and we're still at I don't know, what, 98%, are we?
98%.
Yep. Okay, that may be as good as she's going to get. They've given her, feel like she's adequately pre-oxygenated, she's at 100%, blah, blah, blah. Go ahead. That's pretty good. Preparation is always the key, and obviously part of that preparation is pre-oxygenation and getting that oxygen level up. So y'all did fine, considering.
And something else that I've been seeing from today and yesterday, once you have a direct view of the cords, people are looking away to get the tube from somebody. Once you see,
shove it in your hands. You don't.
You don't have to look for it. Just put your hand out and they'll hand it to you. Once you see the cords, you should have the 1,000-yard stare at them. Do not look away for any reason, because if you look away and you come back, they're going to be gone. The cord's going to be gone. So don't worry about. You don't have to search around, look for anything. You're going to have an assistant.
These guys know what to do, and they'll slap it in your hand. But once again, as I said, on this it may not help. On a lot of these, a little extra room does help. A little downward pressure can help. All that. And if you don't have a good view of the larynx, despite your best efforts, probably better to come out and just ventilate and then talk with your proctor about what, didn't have a good view of the larynx. Is there anything we can change differently? And they might say, well, darn, I should have got that kaleidoscope in here. Let's get it in here. And they can usually get it in and ready to go in about 30, 45 seconds. We want to give you ideal conditions, but the feel for the person is, what this does with is, and unfortunately with this, it's very hard not to hit on those teeth because it's so rigid. On a person, you shouldn't hit on the teeth because it's going to be a lot more feel. And if you can intubate, part of this is eye-hand coordination, and it's amazing how many people I'll see their view of the larynx, and I'll say, and of course. They get the tube, and then maybe they did look away like Matthew, or maybe, and that ends up going into the esophagus. Some of that's nerves too, What's the rule about Whose pulse should you check first at a code? Yours. Right. Keep your left. Few good breaths, stress level down, and it's not, it's a controlled situation. You're not gonna hurt any of these guys. If you fail, you've got to back up with thousands of intubations and airway management experiences behind you that can easily take care of it. So that's great. Take advantage of it. So whatever curve you're like, that you're happy with, make sure your blade is fine. I do, you know, somebody that says I don't check cuffs, make sure that they inflate. I do always check the light because sometimes that's a loser. And nothing more frustrating than going in and finding no light. Okay, so we're pre-oxygenated. I'm gonna come around here. I can't really help you much because she's very, very stiff.
Can I go?
Mm-hmm. And you're going to have someone there holding your tube for you, so you don't have to hold it.
Yeah, absolutely. That's where you can take advantage and play with the larynx if you want, or the cartridges. Great. Okay. That shows you're implanting both lungs. So you got it in the right place.
The first thing is what?
First things.
Negative epigastric, then which lung?
Right. No, left.
Left wide?
Yes, because it will often go into the right.
Right, so if you have left lung sounds, your chances of having a right main stem
Pretty good.
is really low.
Oh, yeah, okay, right, correct. The classical sniffing position on this lady is probably not normal, but that would be like this. And then I don't usually extend them till they're asleep, and then I do like that, you know. So
Okay.
C6, C7 flexed a little bit, like a little, and C1, 2 extended, and that should make it as straight as it can. That's where the stylet's getting to be a little bulky. Okay. I'm happy. Y'all happy? So we're going to optimize. We've got it. We're at 100%. We'll say that it's 3 minutes, and we've been adequate drugs. So you're going to, if you want to ventilate, you can. Here, I'll do this for you. I believe we're ventilating this patient.
I can see it. I just can't get to it.
All right. So what happens if you come across that situation in real life? Are you gonna stay in there and
No,
look
you
around?
come out and
Yeah.
Right. Come out
ventilate.
and reassess. And what's the definition of insanity? Doing the
doing
same
the same thing over and over again with expecting different results.
Right. So what are you gonna do? Change
change
something.
something.
position or blade or
Yeah.
yell at your assistant for not giving you enough downward pressure.
And you can use your other hand, since you're going to have an assistant holding your tube.
Mm-hmm.
You can use your other hand to adjust
Play
the
with
larynx.
the larynx.
Okay.
So-
You're doing great. Don't get You're
So
doing great.
this right here is where there's a key training point is stress management. So you're getting stressed,
Mhm.
which is causing the situation to go south.
Mm-hmm.
Stay focused and relaxed, calm,
Yeah, what's that?
problem solve. What's the problem? You can see the chords.
I'm aiming for the chords, and then every time I go for the chords, it goes into the
Okay.
epiglottis.
Okay. So with the bougie, you're holding it really close to the mouth and trying to like bend it.
Mm-hmm.
Using the bougie is really a straight kind of pass motion. So what I want you to do first, before you have anything else in your hand, is get a really nice view of the chords before you do anything else. And also remember that your workspace is to the right of the blade.
Uh-huh.
You need to be manipulating the tongue and the anatomy off to the left side. Even with a straight blade, we want everything off to the left. And your workspace for your tube, bougie, what have you, is off to the right side.
Can I take the pillow out?
Yeah.
Kept running away from me
Right,
when
so
I went to put it in.
Did you see how when I was using the bougie, I wasn't?
Yeah,
Nice,
yeah. Okay.
It's a very
It's like a finesse.
This one's a lot more floppy than you.
well then use that one.
Topped it in there.
Can I open this one?
Sure.
Schmoozed it.
It's almost like you're just feeding you're feeding her. Help me out here. What do you're just
Threading the needle.
You're threading the needle. Just in the and I mean I hold it back here almost.
Okay. Let's try this again.
Okay. Okay. Looks
Okay.
promising.
Can you thread my tube?
Yay!
Uh-huh.
Okay.
All right, you got this.
All right.
You're in control of the
You can do
situation.
it.
All right.
All right.
Man, far enough. I'm at 22.
Yeah, probably not a problem.
Whoops.
Here.
Thank you. That was exhausting.
But you
It's
did it.
hard. It's hard.
Yay!
Nice.
Yep, you're looking good. Looking good. Okay.
I
And
went in a little.
you can always pull it back. You can always pull it back, right?
You did that like a pro.
Yeah, you did.
Like a boss.
For all of your struggle city.
Yeah. And put that on the upper and just wrap that around like that. Okay. And bite blocks, I much prefer, you can, oral airways have been used by everybody for bite blocks. Problem is oral airways, if you want to really use it as a bite block, what happens when you bite down on a hard plastic airway? You break teeth, and I've done that, or seen that happen before. But I had 2 patients this week that woke up like this, but what they were biting really hard was on the bite block and not on the tube, so we had the situation under control. If you did not have that in, they would have occluded the tube. They take a good breath in because they're breaking up, and they can't get any air in, so the air comes into the lungs, fluid comes into the lungs, and you get a white out on chest x-ray, and you have a patient that, instead of going home in an hour and a half, is going to have to spend the night in the hospital on high-flow oxygen because you let them occlude their airway. Kind of like laryngospasm, very similar.
To make one in the OR, you're not going to have, a commercial device, but this represents my stack of 2x2s, this
Mhm.
paper towel, so just get maybe, 8 to 10 of them,
Make
somewhere
sure
there.
it's bigger than the tube lumen.
Yeah, fold it in half, and then just take some tape and wrap it around your 2x2s, and you've got
A bite block.
And make sure you're not pinching the tongue between the bottom teeth
Mhm.
and the bite block. That can easily happen. And make sure it's just wider than the diameter of the tube, and you've got a bite block. And it works really well. The other thing is that sometimes this comes out. Your hub comes off your tube, and a great fix for that is to take an alcohol swab and get some on there.
No, it really makes it. That's Matthew's good trick, and
And once
It
it
ain't
dries,
gonna go-
once it
it ain't
dries,
coming out.
it's not going anywhere.
whoever's with you is not going to let you. They're going to bail you out if you need to be.
And the chart from their previous case is going to show who intubated them, how many attempts, what blade, what tube. So
Yeah,
it's-
yeah.
So you're
Very
not
good
going
point.
in blind. It's not like we're showing up at someone's house.
A quick airway evaluation on this young lady. Okay, thyromental distance. Actually 4, huge thyromental distance. That's great. 2 or less is the problem. You don't understand what a thyromental distance is from the thyroid cartilage to the tip of the thumb. Okay, and then of course you can have them open their mouth, stick your tongue out. Oh boy, she's a Malin-Patty 1, 2. Boy, this girl is just screaming to be intubated. And then of course neck extension. And then the thing that I've really started emphasizing more, because the Malin-Patty basically shows there's a room for the tongue to go down in the roof of the mouth, so you can push it down and get it out of the way. And it also tells you a little bit about how much fat's in the posterior pharynx and all that. And the other thing is have them bite their upper lip. There. And she does that, so that shows that her jaw can come forward good. So all those things are good signs. This lady you would suspect that she would have good airway. I mean, she would have very good. You would be able to get a great visualization on her. So that's probably the biggies. And of course, if you look at, and they have really prominent incisors, that can be a problem because they have to deal with those. But for the most part, can you see the back of the throat when they open their mouth and stick their tongue out?
Yeah, the canine sharp teeth.
And, and your Malin-Patty, yep, oh, she does that well. Okay, and can you bite your upper lip? Yep. So all those things are good criteria. And of course, nobody gets easier to intubate as they get older. Everything all these joints start fusing and things like that. So neck mobility, y'all are all young, y'all ought to be like this. And and once again, she's pretty much breathing in a sniffing position. Look at her. She's kind of like that. And she wants to know what's for supper. Okay, so yes. The thing about it is, if you suspect, as Matthew said, if you have an anesthetic record, well, the electronic health records, most people, and if they said it was 35 years ago, but ask them, have you been told you had any problems with an anesthetic, any airway issues? Anybody mention that? And most people, we don't do it as much as we used to because we think we do have better tools than used to. But I used to about 2 or 3 times a year I'd go out and give somebody something and said, you were hard to intubate. Next time you come to the operating room, show them this or tell them to go to the medical alert site if you've registered like I told you to, and they can look and have it or find the anesthetic record. And I'll even give them copies of the anesthetic record where I have my note that says they were hard. And that's particularly important if there's somebody that doesn't look like they're hard. And occasionally you run into those folks. They don't look like they're hard, but darn it, they are hard. If you pre-oxygenate, and nowadays, even if you use the longer-acting rocuronium, we now have Sigamadex of Viridion, and you can reverse it within 3 or 4 minutes. So you really haven't burned any bridges. You know what I mean when I say burn bridges, where you don't have any choice. You just say, ooh, it's going to be 50 minutes before they're going to get an airway back and breathe on their own. If I don't either get a tube in or get an airway of some kind, they're going to be 50 minutes, they're going to be dead. Of course, in that time, you can do this number. Okay? So, once again, women just don't have it in there. Okay. Not there, right? Okay. It's not your fault you don't have a big thyroid guitar. It's the way God made you.
Come on, man. Yeah, I'm mad at it.
But yeah, so nowadays, you really can bail out, but as I said, in our situation, we can get a glide scope in the room in 30, 45 seconds and have it ready to go. We can call for help. That's something else that most of the time there's going to be somebody that's at least as good as you and maybe having a better day in the immediate vicinity that's not tied up with the case, either supervisor or somebody in between cases. Just holler, Dr. So-and-so, anesthesia provider to room 4. And that usually gets everybody's attention. So. And of course, last thing, scenarios, you can always get the crash cart in, but you don't really want to get to that. You don't want to crash cart people if you can help it, do you? Mm-hmm. Well, y'all going to be fine. Y'all, if you can take care of this young lady, y'all can sure take care of most of the patients we see. She's terrible. If I saw her, I'd be cutting her neck.
It's hard.
Attitude is important. And one thing that Matthew and a lot of the others have shown, Tyler, some other guys recently, you can tell they really, really want to get better at intubations, and because they realize it is important. It's very much part of what you need to do, what you're doing, and this is a good opportunity. And unfortunately, just because of the logistics of it, and it's hard to not give you as much on real patients as you probably would like. Somewhere around 20 to 30 intubations is probably you've gotten pretty good and pretty comfortable and pretty competent. And some people are just naturals at it, and y'all seem to be pretty good. The last group was real good. As I said, this lady's tough. By all means, don't neglect every patient we put to sleep can be ventilated with a mask, and you need to do reasonable steps to make sure you can ventilate them with a mask. Not everybody's easy. Some people do need the fancy stuff. I'm somewhat reluctant to put in oral airways because I guess because I keep worrying about those dental valves I had to pay 30 years ago. But all means, and oral airway is not a problem unless they wake up and bite down on it. So put it in if it'll make you a better airway. That's thinking ahead, and you get credit for it. If you say, go through the preparation sequence. Look over there, make sure the drugs are ready, make sure the blade is ready, make sure the tube is ready. Make sure the stylet's in a good position, and you have an appropriate size tube. Good luck to y'all, and I appreciate your interest in what you're learning to do, because it is important, and y'all are truly the heroes of the medical community, because you're out there without a lot of help and often tough conditions. And so God bless you all, and hopefully, they said, get your skills as good as you can, because you never know when you're going to need them. The patient is under optimal conditions and under control. And ask the anesthesia, whoever's putting them to sleep, are you using rock or sucks? They're going to be using one or the other, and the difference is If it sucks, you can intubate in 30 seconds, and it probably is indifferent whether you give them a ref or not. With rock, it's going to be 2.5 minutes, and so you definitely need to breathe that patient. And also, if you try too soon, it's going to make you look bad.
You just have to be able to problem solve, step by step problem solve while you're in there, and not, oh, I can't see it, I gotta get out. But what are you looking at? Do I have to come back? Do I need to go further in? Just you maintain control of the situation and know your anatomy. I think is one of the biggest parts of this, is knowing. If you don't know, if you know you're not looking at the cords, okay, what am I looking at, and where are the cords in relation to that, and what steps do I need to take to get to the cords from there?
It's the ideal situation where you have those nice cords like that, 60, 70, 80% of the time, maybe, Matthew. Sometimes, as you said, all you see is the retinoids. Sometimes you only see, if you only see the epiglottis and you try as hard as you can, then you probably do need to back out and ventilate and get a glidoscope in there. Because those folks, but if you can see those little posterior retinoid articulating cartridges, posterior part of the voice box, if you can almost always, you can sometimes make your tube, but you can almost 99% of the time you should be able to make this go in. And Matthew's right. Too close. This is, I think, this is not a bad bougie. And this is not a bad bougie. I mean, this is one I've used hundreds of times. So that little tip, that's all it. As long as you make sure it goes anterior, and if it goes, it almost surely is in the trachea. You don't want to push it. You want to control this stylet. They want to control the stylet, and you thread the tooth off of that, so that stylet, the bougie gets progressively longer. Because otherwise, if you push both in, you could end up with this in the distal airway, and that's not going to be good. No. So, but keep that laryngoscope with that good, because you're basically keeping as good a channel as you can, so that the tube is not going to have as much resistance when you try to, the bougie will have an open channel, and the tube, if it follows, is going to have an open channel. Okay, so don't move the tube out. And then at the end, don't forget that you can do as much damage taking your laryngoscope out as you did putting it in. So don't be very cautious about taking it out to protect the lips and the gums and the tongue and all those kind of things. Okay.